Good evening, everyone. It gives me great pleasure to welcome you to this webinar on breast cancer and COVID-19 with Ms. Joanna Franks, a consultant breast and oncoplastic surgeon at UCLH, and Dr. Adrian Tookman, clinical director of the Marie Curie Cancer Care, both of whom are esteemed members of CHAI's medical advisory panel. March this year marked when CHAI turned 30. From our inception, we gained a reputation for being innovators and leaders in the field of supportive cancer care. And that is thanks to our co-founders, Susan Shipman and my late mother, Frances Weingarten, Alea Shalom. And we want to thank them for their vision and determination to create CHAI. We actually launched the organization with an Ask Expert lecture in Norris Lee Synagogue Hall, and had a full hall, had to turn away over 100 people because there were 400 already in the hall. And it was the first time there had been a lecture on cancer to a lay audience. And it is a tried and tested formula that we have been using for the last 30 years. Tonight, there is a difference because we are on Zoom, which gives us a tremendous opportunity to connect with many people from all over the world. And we are joined tonight from people as far as Europe, Israel, North America, Canada, and South Africa, and those are the ones we just know about. All of us have been affected by COVID-19 in some way or another. The enormity on cancer patients and their loved ones is undeniable. And whilst CHAI's doors may not be open physically, we are continuing to provide our care and support remotely through telephone, Skype, and Zoom. And adapting to the changes continues to be the focus of all of us at CHAI. But you don't have to take my word for it. And I'm going to read from a quote that we recently received. It was from a client who wrote to us, "Normality has stopped. My cancer treatment has stopped. Yet CHAI hasn't stopped and is still there for me." And for this, and for so much more, I want to thank Lisa Steele, our chief executive, for her leadership and galvanizing our dedicated and committed team who continue to deliver CHAI's ethos of a combination of a highly professional service, always delivered from the heart, and which has such a tangible impact on all those who turn to us. And now it gives me great pleasure to hand over to Dr. Adrian Tookman. Adrian headed up the first palliative clinic at the Royal Free some almost 35 years ago. And his CV is extensive. His experience is enormous. And I could go on and on about Adrian. But if I was to choose one word to describe him as a person in every aspect of his personality and his character, I would say that he is a mensch. And for that, we are truly grateful to have you, Adrian, as one of our trustees, as a member of the medical advisory panel, to guide and advise us. And now I'm handing over to you, Adrian. Thank you.
Thank you, Louise. And let me say thank everyone who's joined our webinar this evening. It's a little bit of an experiment for CHAI, so forgive us if we're not technically perfect in this. So once again, thank you for asking me to chair this meeting. I've worked with CHAI ever since CHAI was created many years ago. So it's a wonderful organization. And we're very privileged to have some highly specialist medical and surgical persons who advise the charity through our medical advisory panel. One of which is Joe Franks, a good friend of mine, and as Louise said, an oncoplastic breast surgeon. And our plan is to do the following. Joe is going to present for 10 or 15 minutes. Then I am going to try and field some of the questions, and you can put your questions on the live comment box that's to the right of the screen. And I'll try and pick out the questions so that Joe can answer them for us, and or Joe and I can help answer them for us. This is a talk about breast cancer and about breast from a breast surgeon's perspective. One appreciates that COVID is a huge issue, and therefore we know there's some questions related to COVID. I have been given a message that If you want a web link, it's www.highcancercare.org/webinar. And I'm sure that will actually go up on the live comment box as well. So enjoy the show. We'll be speaking for around about 1 hour. And Joe, over to you.
Good evening, and thank you all at High for inviting me to do this and making it all possible. So for me, it's a little bit strange talking to an audience that I can't see. There are questions available, time to do those, so please send them in. I'm going to talk a little bit about breast cancer to start with. I'm a breast and oncoplastic surgeon, which is a title that some people find a little unusual and somewhat of a mouthful. It means that I deal with all breast abnormalities and in particular cancer, but I would never compromise oncology, but I have very much a plastic surgery view when I'm thinking about how to surgically manage patients. Many people will know someone who's had breast cancer. We expect about 1 in 8 women in the UK to develop breast cancer at their lifetime risk, which means that most people in the audience, if they haven't had breast cancer, will know someone who has, a family member, a colleague, a friend. And it's times like now with Covid-19 when we start to think a little bit about how we manage this during the pandemic, what things have changed and what things haven't. So the first thing that I'm going to say is that in the UK, we expect about every 10 minutes for someone to hear that they have breast cancer. And at the moment, we're down on referrals by 50 to 60%. So that means that there are people we're anticipating sitting at home, worrying about something and not sure what to do about it. So I'm going to talk a little bit about symptoms and signs, what happens when you come to the breast clinic, and how that may or may not be changing during COVID-19. Most women tell me that they don't like to examine themselves, and I don't blame them because they find that they feel a lumpy bit or a bumpy bit and they're not sure what it is. And for those in the audience that are getting older like me, we're also aware that gravity is not our friend. Things don't look quite the way they did before, and that can be a little bit distressing. So if you can't do anything apart from some very simple breast awareness, then I would say just once a month, look at yourself in the mirror and just see that everything looks the same as it always did and one side matches the other. If you can, and most of us don't like to look below the neckline in the mirror unless we absolutely have to, raise your hands up in the air and make sure that nothing is changing one side to the other. So is the nipple pulling in on one side and it isn't on the other? Is there some wrinkling to the skin that you can't see? Is the breast changing shape? And if that's all you can do, then that's a very good amount of breast awareness. And should you notice a difference, then you need to contact your GP. Some women find that they are able to self-examine, and we just say to feel around the breast in a systematic way. Make sure that you go into the armpit, make sure you go all the way up to the collarbone because the breast does go that far, and make sure you feel behind the nipple. And if you see or feel anything that's different from one side to the other or different to the roadmap of you, then we would like you to contact your GP to discuss it with them. Things that people often present with is a lump or a bump, a change in the shape of the skin, the nipple looks different, it gets pulled in, it discharges some fluid, one side looks different to the other. In terms of COVID, we are still seeing patients in the one-stop clinics across London, in all the NHS trusts and the private hospitals, if you have a significant symptom. So if you have noticed something, please do contact your GP. We're expecting at the moment that GPs will probably speak to you on the phone. They may not need to see you and then refer you to the hospital. When you get to the hospital, we'll be expecting that you'll be seen in something called a one-stop clinic or a triple assessment clinic. So you'll see a clinician, very much like myself, who'll give a history and you'll be examined. And then you'll go off to have some imaging. Now, the imaging that you have will depend a little bit on both your age and the clinical findings. For most women who are over the age of around 40, you'll have a mammogram. Many women, myself included, have had this, know that it's not very dignified. And so I would always suggest to women, if you can, to wear either a skirt or trousers. Don't wear a dress because otherwise you're standing naked. practically, apart from your pants, having the mammogram done. You'll get a mammogram in 2 views. It's a little bit uncomfortable. It shouldn't be painful. People do get a little bit distressed sometimes around the amount of radiation exposure for a mammogram. To put it into context for all of you, it's the same as a return flight to New York or a 5-day holiday in Cornwall because of the natural rocks that are there. So it is a very small amount of radiation. And as most of the world is currently grounded and not going on any holidays, we can all risk a little bit more radiation in our mammograms than we had before. You're also dependent on your age, likely to have an ultrasound, and that is a tool for us to look at a focal area that either clinically we have concerns about or feels a bit different, or that we've picked up on the mammogram. And you may or may not then require a biopsy, depending on what we find. Biopsies are usually done in the ultrasound room, occasionally done in the mammogram room, and always with local anaesthetic. All of these procedures are happening in the context of COVID-19 for patients that we have concerns about, and we are very keen for patients to let their GPs know if they have concerns. Once you've been seen in the one-stop clinic, if you need to be called back for a biopsy result, many of these things are happening over the phone. We are trying to reduce traffic and flow in the clinics wherever possible, but patients are still being followed up in person as well. You will find that there is a little change amongst all the clinical groups, and we are trying wherever possible to communicate with patients without them having to come in. We're also trying to get any tests that need to be done on the same day so that people are making less journeys. If you are unfortunate enough to develop a breast cancer and require treatment, I think the most important thing to say is that time critical treatment is happening in the context of COVID. The breast cancer services have been divided across London into different hubs. The teams are working very well together. You will be treated by the hospital that you were diagnosed in, but you may be treated in a different place. So for North, Central and East London, 11 NHS trusts are currently being treated at the Wellington Hospital by their NHS teams. All the patients are COVID tested before they come in. Unfortunately, you can't have relatives with you while you're having your surgical treatment because we're trying to reduce the number of people in the hospital, but we are keeping it as safe as possible. We have capacity for radiotherapy and we also have capacity for chemotherapy. We're starting chemotherapy where it's appropriate. We're continuing chemotherapy where it's appropriate. And for those patients who we think that there may be no further value in continuing with chemotherapy in the context of breast, we're stopping that. All of these things will be discussed with you by your teams. When we are looking at patients and assessing their risk, we are thinking about things like family history. We are thinking about genetic predisposition. Under normal circumstances, we are vigorously testing appropriately people for genetic mutations such as the BRCA gene. At the moment, that's more difficult to do because the geneticists were deployed to other areas of the hospital. I think that very slowly this will come back on stream and we'll be able to continue with that as we were before. For those patients who are considered to be high risk and are having MRI screening, that is still being undertaken within the auspices of the NHS. That didn't stop, so MRIs will continue to happen. For those who are due mammographic surveillance, so those are patients who've had a breast cancer and are due to have a mammogram every year, we are starting to invite people back for these mammograms. I think that now that we have a better idea about what safety measures we need to put in, and we have a greater understanding about how much COVID there is in the community, we feel confident to be able to do this. We are, of course, risk stratifying people by age and those that have been told for other reasons to shield. So you may get a call now requesting you to come in for your surveillance mammogram. If you were in the middle of a breast assessment with disease that wasn't thought to be cancer but did require further biopsies, you may find that again you're starting to be contacted to pick up where things had been left and to continue with that assessment process. You will find that when you attend clinics, the clinicians all have a face mask on. You're likely to be offered a face mask if you don't have one as well. I think it's a little disconcerting because you don't get to see our faces as we're talking to you. Hopefully, there's a lot of communication that comes through the eyes so that you are aware of how we are trying to empathize with your predicaments. Most patients find it reassuring to see the level of questioning that happens before you come into the hospital. Most people don't mind having their temperature taken as they arrive and are happy to see that there is a process for trying to get people to move in an organized fashion through the hospital so that they're not crossing other people in the passageways as much as possible. You may find that there's a delay in clinic while imaging is being done. Most of this is related to the fact that there's increased cleaning of the rooms happening as we are working people through the process. Women feel very anxious about coming to the one-stop clinics. To reiterate what I've always said in the meetings, if I have 20 people coming to see me in the one-stop clinic, I expect to send 19 of those patients home reassured that they do not have breast cancer. That does not mean that you made a mistake coming to the clinic or it was the wrong thing to do. It always gives me great pleasure to give good news to people. So please don't take that away from me at the moment because it keeps us going. If you have a significant symptom or a change and your GP, you've discussed it with your GP and they've sent you up for clinic, no one is going to be upset if we're able to reassure you at the end. We will all just be relieved that there was nothing further that needed to be done at this time. So I think that from that very brief overview, I hope that you will all now feel confident that you should be contacting your GP or medical teams if you have a concern, and that we are able to give time critical treatment, be it surgical or medical, that we can assess new changes, and that we will be doing whatever we can to keep you safe within the clinics. That the environment may look a little different to what you have had before, and certainly there'll be people wearing different uniforms and being very careful with regards to gloves and face masks, but that doesn't mean that we can't manage the concerns that you have. So I'm hoping that Adrian has some questions for me. We certainly had some that were put before the panel prior to this starting. So we'll start to make our way through these. I can't promise that we'll be able to answer all of them, but we will do our very best between us.
Joe, thank you very much indeed. Oh, put your mic on mute, Joe, because that's better. Thanks very much indeed for that, Joe. Very clear, very explicit. I'm just going to reinforce one of the things you said right at the beginning. Referrals have gone down by 56%. The reason to reinforce that statement is clearly and understandably people are very anxious in these times, don't want to leave their home, don't want to go to a hospital. But I think Joe was making it very clear that after that initial phase, the crisis phase of COVID, things are now getting into a much more regulated way of working. So Joe, I'll try and pick up on some of the questions, if that's all right. Is that okay?
That's fine.
Okay, I have a question here. I was supposed to have a Zamita infusion in March, but because of the virus, it's been put off until October. I am on anastrozole. Does it matter that it has been stopped?
No, it doesn't matter that it's been stopped. Please continue taking your anastrozole, and for patients who are on other aromatase inhibitors, drugs like exemestane or other letrozole, we are very keen that you continue taking that treatment. It's a tablet to take every day. The drugs that you're on to improve your bone health can be delayed. They have been delayed across the board for everybody. So as long as you keep taking the aromatase inhibitor, then I have no concerns if you have a delay with your infusion.
Thank you for that, Joe. And yeah, I mean, much of this is about balancing risk, isn't it, really? Self-isolation staying at home has obviously been advised by the government. And obviously, if treatments can be delayed, it's sensible to do so. Another question, Jo, are you ready?
Yeah, I am.
I'm 56 and had, all I can say is you're a lot younger than me, so congratulations. Oh, no, rest of the question, I apologize. I'm 56 and had invasive lobular in one breast, so invasive lobular cancer in one breast, for which I had a mastectomy. I'm on letrozole for the next 10 years. Does this mean that I must not have HRT?
So if you had a lobular cancer and you're now on endocrine treatment, then your cancer is sensitive to hormonal manipulation, which means that your cancer, when it was looked at under the microscope, had receptors which we know it will encourage growth of the cancer if female hormones are around, the kind of things that are in HRT. So the drugs that you're on are, as it were, anti-HRT or anti-hormone treatment. So we would very much recommend that you do not take HRT, and certainly we wouldn't want you to take it in parallel with the drugs that you're on. If you've been advised to have 10 years of endocrine treatment, then it means that the team that are looking after you feel that your pathology showed sufficient changes that you would benefit from extended treatment, not just 5 years, but 10 years. So I would think very carefully about changing that. We know that endocrine treatment has side effects that women find very difficult to tolerate. There are more than one drug available. So if you're not getting on with the one you're on, it may be worth discussing with your team or your clinical nurse specialist whether there's a different drug that you can try. But I would say that you would need to be extremely cautious about HRT. And certainly at the moment, you should be taking the medication as prescribed and talking to your team about side effects.
Great, thank you for that, Jo. Can I just say, if anyone wants to put more questions on live comments, please do so. We did have some questions given to us earlier, and we'll try and tick some of those off, Jo, if that's all right with you.
That's fine.
If you have had breast cancer, are you more susceptible to getting COVID-19?
So currently, we do not believe that if you've had treatment for breast cancer, you are at increased risk of developing COVID-19. We also don't think there's any evidence that should you get COVID-19, you would have a more difficult time with it or a poorer prognosis from it. So I don't think that you should use your previous breast cancer diagnosis to give you too much concern. The advice is the same as it is for everybody. So thinking about your individual risk based on your age and any other tablets that you may be on, so things that may suppress your immunity, that would be what is really going to manage your risk for COVID. We are very keen that patients come to hospital as necessary, but we don't want patients to take unnecessary risk. So if you are over 70, you may be called later on for surveillance mammograms or for your routine appointments. You may find that you are being telephoned prior to coming in to see if you have any new symptoms and to see if you want to defer. We are thinking about trying to make sure that patients aren't making unnecessary journeys to the hospital. So if things can be delayed, we will do so at the moment. And we're also thinking about how patients are going to physically get to the hospital. So for some hospitals, they have a very big car park and it's relatively easy to drive to them and park outside. For other hospitals, such as UCLH, we really don't have any parking. It's very difficult. And patients rely on public transport on the whole. So we're thinking about that as well. So all of these things need to be balanced, but having a previous diagnosis, you're not on any current treatment, such as chemotherapy, endocrine treatment does not increase your risk as far as we know at the moment, although we did have some questions around being female and female hormones and how they protect you. So I don't know if that's the next question that I'm going to be faced with from Adrian.
I suspect I should. So it's reported in the news that men are more susceptible for getting COVID-19 because estrogen seems to protect women. Does this mean that postmenopausal women not taking HRT have the same risk as men?
So at the moment, what we understand and what we can see is that women seem to fare better from COVID-19 than men do. This is almost certainly multifactorial. When the first data came out from China, we thought that some of it may be related to the fact that if you look at the Chinese population, a large number of the men are smokers and the women tend not to be. If you start to see the data coming out from other places, it doesn't seem to be as much related to smoking as we thought it was. We don't totally understand why women seem to be protected, but they are. There are some studies that are looking at hormones and estrogen and whether or not that protects you. I think the jury is very much out now. So for anybody who is taking endocrine treatment for their breast cancer, please continue to take it. Anybody who's taking HRT, if that's what you're taking and it suits you, don't stop it because of COVID. Don't increase the dose either. And for those people who are postmenopausal and have no hormonal influence at the moment, it's very much a watch this space to see what happens. So we just don't have an answer at the moment.
And the other mystery, Joe, is why do women live 7 to 9 years longer than men? You don't need to answer that one.
I'm not going to answer that one.
I have my own answers, Joe, but I don't think we can do this on a public call.
Okay, well, we'll save that for another time. I think from Louise and Lisa, there are some questions about patients who may have the BRCA gene. So many people will be aware that there are identified genetic mutations that increase one's risk of developing breast cancer. The first two that were discovered were called BRCA1 and 2. So BR for breast and CA for cancer, because we're not a very imaginative bunch. And what we found is that if you have those mutations, your lifetime risk of developing breast cancer by the time you get to the age of 80 is significantly higher than the background. So we expect 1 in 8 women to develop breast cancer. And on average, between BRCA1 and BRCA2, you have a lifetime risk of between 70 and 80% of developing breast cancer. We know that it's more common in the Jewish population. We used to exclusively say the Ashkenazi Jewish population, but if you look at the Sephardim, it's there as well. Most of us don't know if we're Ashkenazi or completely Sephardi. When I got married, I told my husband's family that I was definitely Ashkenazi. In fact, I discovered that I have quite a lot of Sephardi blood. So I'm half and half. So I think knowing which side you're from doesn't necessarily help. But we do know that patients who carry the mutation have this increased risk. In general, their options are high risk screening. So that's breast MRI scans from the age of 30. The MRI scans are done once a year and they're timed to your menstrual cycle. Other options are to take drugs like the ones we've already had questions about, but they have quite difficult side effects at the best of times, or to think about risk reducing surgery. At the moment, within the NHS, we are obviously focusing on time critical surgery. So we're not doing risk reducing surgery at present. However, high risk screening is still going on. So patients who would be having yearly MRI scans will still be having them. So if you haven't been called for one and you're due for one, please could you contact your local NHS high risk screening team and see when you're due. It is very important that it's done to your menstrual cycle. It does seem a bit boring to be asked all of these questions as you fill out the form, but in fact, we need to do the scan between day 6 and 16 of the menstrual cycle, with day 1 being the first day that you bleed. because otherwise we end up with a lot of background hormonal change on the scan, which makes it difficult to interpret. If you are one of those patients who is having MRI screening, then you have a 1 in 10 risk of a recall on that MRI scan. That does not mean that you have a breast cancer. It means that we've seen a small change and we want to find out some more information about it. There is a definite relationship between being recalled and requiring further assessment and then making inquiries about coming to see someone like me to talk about risk-reducing surgery. For all the patients who are awaiting risk-reducing surgery, which is currently on hold, if you have not had a recent breast MRI scan because you were due your surgery, you may want to talk to your team about having that done, because it would give you some degree of reassurance to know that your MRI scan hasn't changed. MRI scans are very good at picking up small changes in the breast and are very useful in the high risk group.
Thank you for that, Jo. Much of what we're talking about in terms of screening, high risk, etc., it's all about balancing up the risk, isn't it, really, of yeah.
Exactly. So the reason that high risk screening continued even when COVID was just hitting and most services were shutting down was because the high risk patients are in general young and fit, and therefore it was felt that their risk of coming to the hospital was substantially lower. They're also having MRI scans, so this is not necessarily the type of scanners that are being used for patients in the rest of the hospital. And very often within the NHS high-risk screening centres, those MRI scans are in a completely separate area to the hospital, so they can be to the rest of the hospital, so they can be kept very safe. As with all other patients, it is very important to think about your own individual risk. So you may be young, but you may have a reason that you've been told to shield, in which case you need to think very carefully about whether you want to come for something screening or you want to put it on hold. Once you have a new symptom, especially one that seems to be significant, then that changes that risk balance, and we would like you to come to the hospital.
That's great, Jo. Thank you for that. Is there any danger that a cancer that has spread to other parts of the body might not be discovered during the pandemic? And I think it's a really common anxiety, isn't it? So
for breast cancer patients, those patients that are diagnosed with a breast cancer, we will be looking in the breast clinic at both the breast and the armpit. So we know that breast cancers go from the breast to the armpit. So as part of your assessment, you will have noticed that you have your mammogram and you have your ultrasound. And while they're doing the ultrasound, they spend quite a lot of time with some jelly and a rather large ultrasound probe in your armpit looking at the lymph nodes. If the lymph nodes do not have disease in them, then we are not concerned about spread to other parts of your body, and therefore you would not be having further images. If you have an abnormal looking lymph node, you may or may not have had a biopsy, but at that point you will be referred for what we call staging scans. So this varies a little bit from hospital to hospital, but in general it's some cross-sectional imaging like a CT scan with a bone scan, or possibly instead a CT scan with a PET scan. Staging is being undertaken in the NHS for patients who are recently diagnosed with a breast cancer. There may have been a small delay just as COVID hit, but at this point patients are being staged. So if you were due to have some staging and it hasn't yet happened, please contact your breast care nurse or your team, because they should be able to arrange this. Because we are seeing such a reduction in patients coming to the hospital at the moment, there is not currently a capacity issue for cross-sectional imaging, and so you should be able to get this.
Absolutely right. There is lots of space in hospitals, and there's actually there's lots of space in the imaging departments as well. interesting to see that a lot of people haven't attended hospital, but quite worrying for people like us, isn't it, Jo?
Yes, we don't we feel very anxious that across the board we have lost between 50 and 60% of referrals, and that's not just in breast, that's across all the specialities. So the cardiac clinics, the upper GI clinics, the lower GI clinics. So we have concerns across all of that patients are not coming to the clinics, and we would very much like to see you if you have significant issues balanced against COVID risk.
Okay, Jo, how effective is Zoladex during chemotherapy to prevent infertility in a woman with breast cancer who is in her late 20s?
Well, this is probably something really for an oncologist rather than for me. But what I would say is that when we are trying to protect fertility in younger women, we do use Zoladex injections. The younger your age at the time that you have the chemotherapy, the more likely it is that your fertility will be maintained. The older you are, the less likely. Zoladex certainly has a part to play in this. I appreciate that they can be sometimes quite uncomfortable and difficult injections to tolerate, but we do feel it does have an impact, and therefore it's worth having. But the exact detail for any individual, you'd need to speak to your oncologist.
I would agree with that. Absolutely right. And here I have a question. Hello, I had a bilateral mastectomy and lymph node clearance in one arm 2 years ago, but I still suffer from numbness and some pain in my arm and armpit. Is there anything I can do for this, or will it get better with time?
So it is extremely common to have some degree of sensory deficit after this type of surgery. It doesn't mean that anything's gone wrong. It is just that there are some sensory nerves that often have to be sacrificed in order to adequately remove the lymph nodes under the arm. There are things that can be done. You do need to have some specialist physiotherapy. There are oncology physiotherapists who can really help with this. It is important that we make sure that we get your arm moving properly. Lots of patients get leaflets afterwards for exercises, but they don't necessarily get to go through them with the physiotherapist. You can build up some scar tissue in the axilla, which can be stretched out with the right physiotherapist. And in terms of that patch of skin where you get that change in sensation, you can go through some desensitization of it, because I think it's not just that it's numb, but it can be painful and tingly. And certainly oncology physiotherapists can do this. Some NHS trusts do have this service available. I think that High has a physiotherapy service as well. It's probably not functioning as it was previously, but I'm certain that we are able to do this. Lisa Steele tells me that we can. So I think it is worth contacting High to discuss this, and you can be seen by the appropriate person. Some of the services that we're offering working very well over media such as Zoom and Teams. Others you need to be on site, and those obviously can't happen at the moment, but there's a lot of assessment that can be done using technology, and it may be that we can offer some simple things to start in the first instance. So even after 2 years, you can see a massive improvement of that with the right help.
Thank you for that, Jo. I'm a BRCA carrier and considering a double mastectomy to reduce my risks. I'd like to know your thoughts on this, please.
Well, I'm a surgeon, so obviously I have a slight bias for this. What I would say is that risk-reducing surgery is something that I do carry out regularly. Obviously, it's a little curtailed at the moment, but I have a regular program for it. I think it is a excellent strategy for the right person. I think it needs research. You need to find the right team for you. So whenever you're being treated for a condition, it's really important that you have a therapeutic alliance with your team. So that means that you may not like everything that we have to say to you, because often we have to broach difficult topics or deliver very difficult news. But you should feel that at least it was the right person that gave you that information and was able to support you through it. So that's the first thing. It's not a decision, risk-reducing surgery, that should be taken lightly. It is completely irreversible. So you cannot say afterwards to me that this was a terrible idea and can you put it all back as it was before, because the answer is simply no. An immediate reconstruction will give you the very best cheat that we can, but they will never be the breasts that you have now. Now, for some people, we can improve things. So there are some women who would always like to be a little bit bigger, and very often we can achieve this. There are some women who have always wanted to be smaller, and very often we can achieve this. Most women of a certain age would like to be a bit more perky, and we can really try and improve that for you. What we can't do is guarantee that the breast is going to feel like it did before, and we can't guarantee that it's going to be symmetrical one side to the other. Although if we all stand in the mirror and stare at ourselves enough, we'll see that we're not symmetrical, any part of us. You also need to think about things like nipple preservation. For some patients, that's very important. For some, it isn't. In some patients, it's very easy to do surgically. In others, it's much more challenging. But the most important thing to know is that if you do have nipple preservation, you have to understand that the nipples will be entirely ornamental. So there will be absolutely no sensation and there will be no reaction either. So I would say that I think it's an excellent operation. I think that you need to find the right team to do it. There are many different ways of doing risk-reducing surgery with immediate reconstructions using both implants or your own tissue. There are pros and cons to both. You need to be with a surgical team that can show you examples of what they've done before. And for many of the big teams that do this, so I do some of my work with the plastic surgeons at the Royal Free, we have well, in the past, we've had something called show and tell. I think it's going to take a little while before we can set that up again, where patients who've been down this process will actually speak to you without the surgeons in the room to give you a real view of what it's like to undergo the surgery. Many of these women will allow you to look at their reconstructions and also to touch them, and will give you an idea what it is like to go through the surgery, a realistic view of what the recovery is like, and also what it feels like to have either breast implants or use your own tissue. So I would highly recommend that you get involved with one of the services like that, so that you have a real idea of what you want.
Thanks, Adrian. And I think what we'll do is a question just to tie into that answer. Do you think every woman diagnosed with breast cancer should have a mastectomy, no matter what the stage is?
So no is the answer to that. I think that breast cancer is two words, and it's hundreds of different types of cancer, because everything is now highly sophisticated, from the information we get from the biopsy, the information we get from all the different multiple modalities of imaging. You need to take into account patients' family history, their age, what other medical problems they have. There are some cases which are very suitable for breast conserving surgery. There are some cases where it's extremely clear that patients require a mastectomy. There are some cases where we can do now much more fancy surgery than we used to, so using the Oncoplastic side in order to achieve things. So, for example, if someone has a larger, more droopy breast, even if they have quite a large cancer, I may be able to remove that and do a breast reduction at the same time. That may be an operation that they've been thinking about for years, and would be something that they would be very grateful to have, and would make them actually feel happier about their body shape afterwards. The thing that patients need to be very clear on is that for most cases of breast conserving surgery, or if you're in the States, a lumpectomy, then it's not just about the surgery for local control, but for the vast majority, there will also be a requirement for radiotherapy. So radiotherapy is not something that all patients want to have. It has its own set of side effects. It does require regular appointments at the hospital. So it isn't one size fits all. It's never been one size fits all. So mastectomy is the right operation for some patients. Breast conserving surgery is the right operation for other patients. And it's a very personal decision. So if I have a patient who has a very small cancer with a good prognosis, who could manage with breast conserving surgery, but is very keen for a mastectomy, then I'm happy to support them along those lines. If I have a patient who has a larger cancer, but really would like to have breast conserving surgery, then I'll support them along those lines where it's oncologically safe. Sometimes that requires an operation, as I said before, where we might think about reshaping the breast. Sometimes it requires giving some treatment first to shrink the cancer. So it is definitely a personal decision, and one that each patient should take with their team.
So important. Personalised care, isn't it, Jo?
Well, it's all about personalised care now. It's not one size fits all. There's many different ways of getting to the same endpoint, and it is a much more sophisticated process than it used to be. We used to be able to do 2 operations and that was it. Now things have changed considerably.
Thank you for that, Jo. I'm going to ask a question that was sent in earlier. If you have had breast cancer on one side, postmenopausal, no other risk factors, had 5 years of taking letrozole, are you still likely to get cancer again, either on the same side or the other side after you finish letrozole?
So most patients who have letrozole will have it for 5 years. Some will have it for 10 years. It certainly gives you protection for both the affected breast and the contralateral side. In general, we follow patients up with regular mammograms for 5 years because we think that is the time when you're at greatest risk of a recurrence. Once you've got past that, it's a little bit variable, like all of things, dependent on family history, age, presentation, and so on. But the risk is approximately 1% per year from years 5 to 15. So over that next 10-year period for developing a breast cancer. So we say about 10% over by year 15. And you could have disease in the breast that was operated on if it's breast conservation. You could get contralateral disease, so a breast cancer in the contralateral side. If you've had a mastectomy, you can still unfortunately get a recurrent cancer because however you have your mastectomy, there is a chance that there will be a few breast cells that are left behind. So it is very important that you keep an eye on the mastectomy scar, if that's what you have, on the conserved breast, if that's what you had, and on the contralateral side. And we would continue to support breast awareness and coming to see us if you have any concerns. What people need to recognize is that your risk of developing breast cancer increases with age. So the 2 biggest risk factors for developing breast cancer are being female and getting older. So once you finish your letrozole, you are getting older, and therefore your risk, if you think about even the background risk of developing breast cancer, has gone up.
That's great. Thank you, Jo. And once again, a connected question. Do you think I should insist on having continued screening for breast cancer, no matter what my age, once I've been cancer-free for 5 years? So I speak with someone with breast cancer. I wonder because the NHS say that I won't routinely get either breast or cervical cancer screening. Now I'm over 65, not sure whether to see whether I get screening privately or not.
So all women who are diagnosed with a breast cancer could or should expect to have mammographic surveillance at the hospital that they were diagnosed at, or if they transfer their care to another hospital, for 5 years. So that would be mammograms for 5 years. If a patient is young and their cancer was hard to spot on mammogram, they may get an MRI scan as well as a mammogram for 5 years. Ultrasound is not a screening tool. Once you've completed that, you should be discharged back to the National Health Service breast screening program, and you should receive a call for your mammogram once every 3 years. So that is done via your GP, should put you on the list. If not, you can phone up your local screening service, depending on your postcode, will depend on where that is. You will be screened every 3 years. These are the mammograms that patients often get called to an unusual location. So sometimes there's a van in Sainsbury's car park. Sometimes it's attached to a hospital, so there may be a van in the car park. Sometimes you go into the hospital itself. Once you reach the age of 70, so we are screening women up to the age of 70, you can still continue to be screened on the NHS. However, you will need to opt in. So again, you need to phone up your local screening unit and say that you want to opt into the service and you wish to continue screening past the age of 70. You will then be called every 3 years. It's usually a very good service. All the mammograms are double read, so that means that 2 separate radiologists will report on your mammogram to make sure that they're not missing anything or to reduce the risk of that. They will have your previous mammograms to look at, because after all, with mammograms, what we're looking for is subtle change. If there are any concerns, you will be called back to an assessment clinic. That does not mean that you have breast cancer. Please don't avoid coming to an assessment appointment if you have called for one. It may mean something just as simple as the film is a little bit blurred and the radiologist won't report on it. It may mean that they have not actually captured the whole of the breast and therefore we want to get a better view of it. It may mean there's a small change that is benign, non-worrying, but we want to be absolutely certain of it. So these things these appointments are then made for you at the assessment centre. So you very much can continue to have your mammograms. You don't need to pay for them privately. If you wish to pursue mammograms more frequently than every 3 years, then you can arrange for these to be done privately. I would be careful where you pick to have them done. It needs to be somewhere where they are following similar guidelines. So they're being reported by more than one radiologist. They are getting your previous films and looking for subtle changes. In most units that offer this service, you can self-refer as long as you have a GP and the result will be sent to the GP. In general, we say to patients that you could think about having a mammogram if you wanted to have screening at intervals between your national health ones, about every year to 18 months. We don't recommend having a mammogram more frequently than that unless you have a new change. If you have a new change, you need to be seen by a clinician as well as having a mammogram. If you are worried about a change and you have a screening mammogram and is reported as normal, that does not mean 100% that your breast is normal, because there are things that do not show up on mammograms. So if you have a concern, it is important that you have a clinical review as well as up-to-date imaging.
Yeah, and I think you probably answer the next question. I'm trying to link this in. So I've been told I cannot have NHS mammogram checks now that I'm 76, although I have had breast cancer. Is the case, and if so, should I have private mammograms? I think you've really answered that too.
Yeah, so you can opt in. So you're due your next one 3 years after your last one. So please do opt in and make sure that that gets done. If you can't get that done for some reason, then yes, you can have it done privately. But I would very much recommend trying to go down the NHS route first.
And again, another linked question. I'm not having mammograms as I had a bilateral mastectomy 2 years ago. So I see my oncologist every 6 months. Is that right?
Yes, once you've had bilateral mammograms, you will not have regular mammographic surveillance because there is no breast to mammogram. However, you should have clinical review, and this can be done either by your oncologist, who will be a breast oncologist and used to breast examination, or by your breast surgeon. Some patients, if they're seeing their oncologist every 6 months anyway, will continue just to have it with the oncologist. If you're seeing the oncologist, if you're no longer seeing an oncologist, then you may wish to see a breast surgeon to provide this service. Or you may just, if it's a number of years after your surgery, you may just be happy with breast awareness. It really is about knowing the roadmap of you. So if you have mastectomy scars or you have reconstructions, you need to know what they feel like, and any changes need to be reviewed. And you would usually start with an ultrasound under those circumstances. but there is no role for screening ultrasounds. It would just be clinical review.
And I'm going to probably ask, in terms of time, it's 9 o'clock. I'm going to ask you the last question, Joe. I apologise if I've left out some questions that the audience have put in either prior to this meeting or during the meeting. I'm on HRT, following having ovaries and tubes removed, and it's got in brackets BRCA, so I presume it's BRCA. Does this increase my risk of breast cancer?
So once you've had your ovaries and your fallopian tubes removed, then we feel much more comfortable about you taking HRT in the context of BRCA. Clearly, if you have it will depend a little bit on your age. So for most women, we don't expect to go through the menopause until around the ages of 50 to 55. So if we have given you a medical menopause, then taking HRT should not significantly increase your risk, although we do know that increased hormonal load can. We also need to balance that, like everything, against your menopausal symptoms, your bone health, etc. So it depends a little bit on your age. It depends a little bit on what dose you're taking. You may have not wanted to think about risk reducing surgery, which is to the breast, which is perfectly acceptable. If you are on HRT, then I think it is important that you remain breast aware and that you are having your regular high risk screening. We know that HRT increases the density of the breast, so that can make mammographic surveillance more difficult. If you're high risk because you're a BRCA patient, you will probably be having MRIs as well. You certainly will from the age of 30 to 40 and then on to 50. Once you're post 50, sometimes it's just mammograms, but breast density will affect that. So we used to be perfectly happy about it. We now think there is a slightly increased risk, but it depends a little bit on age.
And I've been asked to ask this question, so I'm going to ask it. But I think we need a very general answer to this one. And this is about COVID risk and having chemotherapy. And I'm just reinforcing the fact that we're not oncologists. We might be able to give you a very general answer. So I'll ask you one question, Joe, and then, as I said, apologies to those people we haven't been able to answer their questions. There is a limited time. I have secondary breast cancer and I'm on capecitabine. I am 65 with 2 kids, 17 and 22. They need to go out for their mental health, live in a small house, and I'm shielding. How do I best manage this? Now, what I'm going to say to you, Joe, is I don't think we can answer this question directly.
No.
But I can give a general, broad answer because clearly this is a discussion that these guys need with their oncology service. Joe.
So there are many patients who are currently having chemotherapy. They are maybe having chemotherapy for the first time. They may be having chemotherapy because they have secondary disease. It may be something that they're on long-term chemotherapy. We know that different chemotherapies affect immunity in different ways, so it varies a little bit depending on what you're taking. We do want patients to shield as much as possible. However, we do need to think about the fact that most patients don't live in isolation and can't live in isolation, and that their relatives need to take out activities to support daily living, such as food shopping, which is important, and also will need to have things like fresh air in order to improve their mental health. So what we would say is that the patient needs to shield as much as they possibly can, and their relatives need to be as sensible as they can and take all the necessary precautions. So we hear about it all the time in terms of keeping social distancing, making sure that you're washing your hands, and where if you were to develop any symptoms, making sure that you stay away from the person that is being shielded. But it is very variable because chemotherapy has vastly different effects on people's immunity based on the drug that you're on, but also each patient can have a different response to their chemotherapy. So some people's immunity will stand up to it very well, and some will be completely knocked out. So it is extremely, extremely different.
Very individual, and one can fully understand all the anxiety that people have who are having chemotherapy and at risk of infection. I think the other thing to say is my personal thoughts on this is that I have had several patients who are immunosuppressed and have had COVID infection and have actually been okay. So it's very variable the way this infection affects people.
The same with our experience and across other trusts as well. So there are patients who are immunocompromised who get COVID and who have a very mild transient illness. It is not predictable.
It's very unpredictable and not well understood, which is probably leaves us with a lot of uncertainty, but I think we have to be very honest with our audience. Can I hand over to, so first of all, Jo, thanks, fantastic. I'm very enlightening, and thank you for your time. I'm going to hand over to Louise now. Louise?
Okay, thank you. Thank you so much, Jo and Adrian. We really finished off on a very positive note, patients recovering, and it was highly informative, and I think the word is reassuring, and I really thank you from everybody. The comments we're getting are very, very positive. We would like to plan further webinars, and we would very much welcome you and encourage you to send us any subjects or particular topics you would like us to organize. And the last thing, if we didn't manage, there were a slew of questions, if we didn't manage to answer all the questions, you can send them email to Lisa S at highcancercare.org. Lisa Steele is our Chief Executive. It will all be treated with tremendous privacy and confidentiality, and we can pass them on to Jo. So please do be in touch. Thank you all for joining us, and looking forward to welcome you to further events. Thank you and stay safe. Good night.